Hello guys, welcome you at your YouTube channel for medical student. So guys, today we will discuss about the important topic of emergency, that is burn. The objective of these topics are introduction, epidemiology, definition, type of the burn, classification of the burn, estimation of the body surface area, pathophysiology, clinical features, treatment, rehabilitation of the phase management basis, complication of the burn, and burn prophylaxis we will discuss here. And there is the burn are the leading cause of the unintentional injury in children, second only to the motor vehicle accident or crashes, and fortunately it has been declined the incidence of burn due to the stronger focus on the burn prevention and treatment. And there is increased fire and burn prevention education, greater the availability of the regional treatment centers, widespread use of the smoke detectors, and great regulation of the consumer products, occupational safeties, and social changes such as reduction in the smoking and alcohol abuse is declining the incidence of the burn. Epidemiologically, it is very important in pediatric age group having 0 to 4 year of age, highest risk of the burn injury, and principal cause at this age is the scalp burn injury, and it may lead to the flame injury in case of the 5 to 14 year of age, and fire is the major cause of the mortality in the children, around 34% in less than 16 year of the old child, and approximately 18% of the burn are result of the child abusing. And burn is defined as a result of effect of the thermal injury on the skin or any other tissues, and human skin can tolerate 42 to 40 degrees centigrade of the temperature, but more than it there high temperature there may be severe tissue. Less than 45 degree is the reversible, but more than 45 degrees centigrade there may be some protein damage which exceed the capacity of the cell to repair. And there are different kind of the burn. Is the scalp burn is the most common type of the burn found in the household injuries as the water or liquids or food, and there may be some flame injuries due to the LPG gas, gasoline or kerosene or burning houses injuries, and there may be some industrial or chemical burn in the laboratories has found acid burn is more common than the alkali burn, and radiation injury may also found due to the X-rays, radioactive radiations, or some nuclear bomb explosion, or electrical injuries very worsen from than other burns, while the entrance and exit wound may found in case of the electrical injury, and there may be causing cardiac arrest, cardiac arrhythmia, and other respiratory distress or respiratory depression may also be found in case of the electrical injury. The burn is classified on the basis of the depth of skin tissue invasion as superficial burn, deep burn divided into deep superficial and deep dermal, and there is full thickness or deep burn. And so there is superficial thickness burn is first degree burn having epidermis involvement only, and this is very painful and dry erythema, and there is no blister is found in case of the superficial thickness burn, and they heal in 2 to 5 days without any scarring. In case of partial thickness burn, which is superficial, is second degree burn found in the epidermis and superficial papillary dermis involvement, very painful one because of the nerve and vascular areas very much in that area, and blister is found with the clear fluid involvement, and they heal without any grafting in 5 to 21 days. And partial thickness deep burn is the second degree burn in deep dermis involvement or reticular involvement of the dermis with the destruction of the nerve cell which reduce the sensation, and fixed red staining may found and they heal if there is no infection in 21 to 35 days. And full thickness burn or deep burn is the complete skin involvement with the subcutaneous tissue and fat with the other bony and other structures. There is insensate because the nerve destruction is completely there. There may found the dry skin with the HR and leathery and thrombose areas found there, and this kind of the burn required grafting. Before to go ahead, we should know about the estimation of the body surface area with the rule of 9 is used in the adults, where the body surface area is divided into 11 parts and the genitalia is having 1% of the burn and other rest of the 11 part having the 9%. And rule of palm is the used for the less than 10% of the body surface burn area is involved, or small area of the burn is involvement, while the Lund and Bronner give the most appropriate method to count the body surface area in the burn in pediatric age group. So the rule of 9 having the 11 area divided into the 9% in adults with the 1% area of the genitalia. While in the pediatric age group, this is having some differences, as the head having the much higher body surface area. So it having 18% instead of the 9% in the adult, and lower limbs having 13% per limb instead of the 18% in case of the adults, while the genitalia and other surface having the similar as adult is the front chest and front abdomen having the 99%, back chest and back lower back having the 99%, arm having the 9% of the right arm, left arm having the 9%. While the rule of palm is used for the small burn areas, as if the area of the palm is counted as around 1% of the body surface area. If the patient is counted as the finger crease to the wrist crease is as around 1% of the body surface area. And while the Lund and Bronner give us a specific or more appropriate method to use the body surface area, as the head having the body surface area is in the newborn and children is much higher than the adults, while the legs and lower limbs having low body surface area as compared to the adults is the 26% in the newborn, 29% in the 3 year of age, 6 year of age having the 32%, and the 12 year or more having the 38%, while the head having the 18% of the body surface area in the newborn at the age of 3 year having 15%, and 6 year having 12%, and at the age of 12 year or more having the 6% of the body surface area of the head and neck, while the trunk having around the 40% in all age groups and arm having around 16% in the children. Pathophysiology is very important of the burn. If the burn or heat is come into contact with the skin, there the coagulation necrosis is started, which release the vasoactive peptides which alter the capillary permeability. Due to this loss of fluid having due to the leakage of the third space areas. Due to this, severe hypovolemia is there. H kind of the hypovolemia, preload is decreased, so the decreased cardiac output is there. Due to the myocardial function is decreased, as well as decreased renal blood loss causing oliguria, renal failure, as well as there may be pulmonary resistance is altered, due to which pulmonary edema, and as well as there will be infection of the systemic areas. Due to this, systemic inflammatory response syndrome will be there, causing MODS or multi-organ dysfunction syndrome along with the shock. So there is inflammatory process ongoing for the burn wound, causing the 3 zone of the injury in the centrally necrosis zone or zone of coagulation is found, which is the closest to the injury sites, or there around the zone of coagulation there is the zone of stasis where the poor perfusion is found. Initially bival tissues found at that area, and further necrosis lead to the deeper wound is the vascular thrombosis may found there. And in the zone of hyperemia is the most peripheral areas where the increased capillary permeability, and this is uninjured or normal skin with the physiological increase in the blood flow in response to the local tissue injury. So the clinical feature, as I told you, there on the basis of the superficial thickness, partial thickness, deep thickness or full thickness burn is required, different kind, and there may be hypothermia in large burn area. If there may be some fluid and electrolyte imbalance, decreased urine output, poor skin integrity, hyponatremia or hypernatremia along with the hypokalemia or hyperkalemia. Hematocrit level may be increased or decreased, and elevated blood urea nitrogen, oliguria may be there, and decreased gastrointestinal motility is found. So guys, treatment should be based on the outpatient or inpatient basis. Outpatient management is done for the less than first and second degree burn with the less than 10% of the body surface area. If the patient is not inadequately judged or there is some child neglect or abuse, that should be hospitalized. There is no requirement of the tetanus booster unless the patient is not fully immunized or prophylactic penicillin therapy is not taking. Blisters should be left intact in case of the OPD treatment and dressed with the topical antibiotic as bacitracin or silver sulfadizine cream to be applied. And dressings should be changed on the daily basis, and it should be washed out the old creams or remove any cream left with the lukewarm water. So there are some indication of the hospitalization as the body surface area burn in the children is more than 10%. In case of the adult, it may be more than 20%. All kind of the third degree burn should be admitted. Electrical burn, any chemical burn, inhalational injuries, any injury adequate to the environment, suspected child abuse or neglected child, or any burn of the face, arm, hand, feet or genitalia, any burn in the patient with the pre-existing medical condition that may complicate the burn, or if there is any acute recovery phase, or if the burn is associated with the any injuries like fracture or others, and in pregnancy, the hospital indication of the admission. So in the hospital there is the 4 phase of the burn care on the basis of the phase, physiological changes, and there is some objective. As the initial phase of the resuscitation or evaluation is around the 0 to 3 days of the burn, where the massive capillary leaking is found may lead to the shock. So initial resuscitation with the fluid resuscitation is to be done through and thorough evaluation of the patient to be done at this stage. And in day 1 to day 7, there may need of the biological closure in case of the all kind of the full thickness wound and HE biological closure. In definitive wound closure may be done in case of 7 days to 6 weeks of the wound. There is continued catabolic states with the risk of non-wound septic events. They may replace the temporary closure to the definitive cover and close the small complex wounds. And ultimately, rehabilitation, reconstruction and reintegration started day 1 to the throughout the discharge with the banning of the catabolic state and recovering the strength. And initially there is the maintain of the range of we should maintain the range of motion, reduce the edema which may cause constriction, and subsequently to strengthen and facilitate the return to the home and school and to the workplace. So guys, in the hospital management we should initially we should done the first aid, including the washing of the wound, removal of the death or devitalized tissues, general assessment and the cardiopulmonary stabilization is to be done, and establishment of the IV lines with the blood studies, and fluid resuscitation is to be done with the electrolyte management, prevention of the infection and early excision of the grafting, and control of the pain and psychological support to be given, and provision of the energy requirement and nutritional support is very important part of the management, and use of the biological or synthetic dressing to close the wounds. And the first aid measure, having the extinguishing some flames by the rolling in the ground, as you should roll at the ground, you should not run away or at the burn site. So the fire or smoke having some area between ground and the smoke, so you should roll or go under the flame. And we should cover the child with the blanket or coat or carpet, and after determining the airway in the patient, we should remove the cloth of the child and construction accessories like the rings or any ornaments during the edema phase, because may lead to the constriction injuries, and brush off the remaining chemical or HR if having, wash the irrigate, or evidently we should clean the wound, and cover the burn wound with the clean dry sheet, and apply cold if there is small injuries. In case of significant or large body surface area burn, we should dress but should not apply the cold, because it may cause hypothermia, and if the burn is by the hot tar, it should be removed. And initial procedure as ABC management, as the administer oxygen, maintain airway, fluid infusion to be given and started immediately, nasogastric tube insertion to be done for prevent the gastric dilatation, vomiting, aspiration and suction is to be done, urinary catheter to be applied for the measure the urine output. Bait is very important and has to be taken initially and daily should be taken, and local treatment should be delayed if the patient having respiratory distress or shock is not controlled. Hematocrit and bacterial culture is very important thing and it should be signed. Fluid resuscitation on the basis of the Parkland formula is 4 ml of the Ringer lactate solution per kilogram per body surface area that is burned. So if there is a child of 10 kg having 20% of the body surface area burn, we should give the 10 into 20 into 4 as 800 ml of the total resuscitation fluid to be given, as half of that should be given in the first 8 hours after the injury or burn, and next half is to be given in next 16 hours. So guys, our goal of the fluid resuscitation is to maintain the pulse and blood pressure, adequate urine output to be maintained, as in pediatric age group it should be 1 ml per kg per hour, and in adult it should be more than 0.5 to 1 ml per kg per hour. And vital signs, acid-base balance and mental status reflect the adequacy of the resuscitation. So guys, if the patient having burn is around the 30% of the body surface area, we should inject a large venous access and central line can be inserted, while in case of the more than 60% of the burn, we should insert a multi-lumen central venous catheter or to resuscitate fluid very frequently or very largely. So a child of less than 5 years of age may require the additional 0.5% dextrose in the first 24 hours of the resuscitation, and colloid is usually started in 8 to 24 hours after the burn. 5% albumin infusion may be required to maintain the serum albumin level as desired 2 gram per deciliter in case of the body surface area is much injured or there is large injury. Infusion of the PEG cell is required if the hematocrit level is less than 24% or hemoglobin is less than 8 gram per deciliter. In some condition where the cardiorespiratory illness or systemic illness or there is hemoglobinopathy or any ongoing blood loss, repeated excision is or grafting is required, full thickness burn में, so there may be label as maintain more than 30% hematocrit or more than 10 gram per deciliter of the hemoglobin, so PEG cell infusion may be required. Fresh frozen plasma is indicated in case of the prothrombin level or coagulation profile is deranged, where the prothrombin level is more than 1.5 times of the control or APTT is more than 1.2 times of the control, where the children having bleeding or planned schedule for the invasive procedure as grafting procedure. And FFP may also be required in case of the less than 2 year of the child having more than 20% of the body surface area burn. Electrolyte maintenance is also very important things. Having the hyponatremia due to the application of topical antibacterial such as silver nitrate solution, where the body surface area is more than 20% burn, there is hyponatremia. Sodium supplementation is required to maintain the serum sodium level is more than 130 milliequivalent per liter. In young children less than 5 years of age is especially susceptible to hyponatremia and cerebral edema. As well as potassium supplementation is also required to maintain the serum potassium level more than 3 milliequivalent per deciliter. Oral supplementation is to be started as soon as possible within 48 hours of the birth, with the milk formula, any artificial feeding, homogenized milk or soya based product can be used by the bolus or constant infusion through the nasogastric tube or a small bowel feeding tube. Prevention of infection is the very important with the dressing, and it can be done by the systemic or topical antimicrobial agent. Prophylactic penicillin is the controversial use, but it can be used in case of the large burn injuries, and periodic replacement of the central venous catheter is required. In case of the penicillin resistant, erythromycin is the drug of alternative to use in the children. Topical antimicrobial agent, infection control of the surrounding, dressing with the sterile and clean techniques to be done, and start early enteral feeding as soon as possible to decrease the intestinal permeability and prevent the endotoxin intestinal transoculation. Topical antibacterial therapy reduce the number of bacteria and penetrate HR and effective. This is very cost effective, and silver is the bactericidal as well as the bacteriostatic agent, and silver sulfadizine, silver nitrate and mefenide is to be used. Bacterial culture has to be sent before to application of the topical as well as the systemic antimicrobial agent, and before reapplying the clean previous application of the cream or antimicrobial agent should be washed out or clean. In case of any extensive full thickness burn, a hard thick eschar can combine with the massive edema which cause tourniquet effect, and it impair the circulation with the loss of sensation and the motor function. So it should be relieved by the surgical incision through the constriction eschar. As you can see in these pictures, there is escherotomy is done, and fasciotomy may need in case of the incision through fascia to relieve the pressure that would otherwise compromise the circulation. Wound debridement is very important part where the dead or debris delays the epithelialization process. So it should be done to remove the contaminated tissues that protect the invasion of the infection, and remove HR and prepare for the grafting. There is different kind of Wound debridement is the natural debridement where the dead tissue separates spontaneously, and in mechanical debridement we use the surgical instrument to remove the debris, and in the surgical debridement we remove the dead tissue or debilitated tissue with the surgical instrument with the wound closer. And there is requirement of the skin grafting in case of the deep third degree burn having the more than 10% of the body surface area is benefit as early excision and early grafting with the infection and other things. If the purpose of the skin grafting is to decrease the infection risk, prevent the loss of protein, fluid and electrolyte, and minimize the fluid loss through the evaporations. And there are different kind of the skin grafting or wound grafting. There is the biological dressing, is the homo or heterogeneous graft. Biosynthetic and synthetic dressing may be found. Autograft or allograft or dermal substitute may be found for the grafting. Guys, there is very important point. The pain should be relieved as soon as possible. Then it is inevitable during recovery from any burn. There are three types of the pain reported by the patient as background pain having the all time as 24-hour pain, procedural pain as the time of the dressing or manipulation of the wound is we are doing there, and breakthrough pain or due to the analgesic having low level in the blood. So medication can be used for the pain relief as the opioid IV administration, but there is some limitation in the children. Morphine can be used as the oral, IV bolus or parectally. Anxiolytic agent as the midazolam or lorazepam can be used, and risperidone can be used to relieve the psychological effect. Nutritional support is very important. As early, it should be started as early as possible, and our goal is to promote the state of the positive nitrogen balance by the optimum nutrient utilization. There is protein requirement around 1.5 to 4 gram per kilogram of the body weight per 24 hour. Lipid and carbohydrate is to be included, and caloric support as 1800 kilocalorie per meter square per 24 hour as a maintenance, along with 2200 kilocalorie per meter square of the burn as in per 24 hour. So guys, additional calorie supports to be given, and enteral feeding can be started as soon as possible with the oral high calorie or high protein meals as supplements, and additional vitamin supplement and mineral is to be required. Hypermetabolic effect with the oxandrolone as an anabolic steroid. Assess for the risk of infection by the parenteral route, and curling ulcer may found in case of the acute injury. So what kind of the disorder may be found in case of the wound healing, as there may found as the hypertrophic scar, hypertrophic keloid, failure to heal, and constructure formation or contracture of the joints. Rehabilitation is the very important phase where in case of the recovery, patient required the rehabilitation as encompass from the time from wound closure to discharge and may beyond, and overlaps the acute phase. It minimizes the function loss and provide psychological and psychosocial support to the patient. Scar management is very important as cosmetically, and it required as pressure therapy or ultraplase laser, and school re-entry is very important point to rehabilitation. Complication of the burn as the neuronopathies, heterotrophic ossification, hypertrophic scarring, contracture may be found, wound breakdown may be there, gait deviation, complex regional pain as post-traumatic psychotropic disorders, and joint stabilities may be there. So guys, burn prophylaxis is very important point, as we can prevent the fire with the installation of the smoke detector, control the hot water thermostat in the public building, as where we can fix the maximum water temperature as less than 49.9 degrees centigrade. Keep fire matches and lighters out of the reach of the children. Avoid cigarette smoking, especially at the time of bed. Do not leave lit candles unattended. Use caution when cooking, especially with the oil, and keep cloth item of heaters. As well as we can prevent the injury with the rolling edge below the smoke, and practice escape the procedure and crawl beneath the smoke. Use educational material as provided by the government as much possible. So guys, there is some manomics, keep in your mind, is related some terminology or some term with the burns are as they are BURNS, burns, having the B for bolus, breathing, and body image, U for the urine output, ulcer and wound management, R for the rule of 9, resuscitation and rehabilitation process, N for the nutrition as soon as possible, and S for the shock treatment and topical antibiotics as silver sulfadiazine. So guys, it is all about the burn. So guys, how was the class? If you like it, so press the like button, subscribe the channel if you did not yet, and press the bell icon to get our notification as soon as possible, and share this lecture to the medical student and other required students. So guys, we will meet again with the next topic as drowning. Thank you.